want to briefly introduce our medical and behavioral health panel. The short story is that I was doing visits. We were seeing kids get sicker and sicker, as we talked about earlier. Kids were starting to die. And the lead attorney on Flores said, you know, bring in more attorneys because we have so many kids, and see if you can get some doctors and maybe child psychologists to help out. And so I sent out an email to the clinic listserv, which is to like, few hundred people in my circle, and it went viral to the point that I was receiving 10,000 emails a day, every day, for weeks on end, from Americans all over the country who said, I'm a firefighter, I want to do something. I'm a yoga instructor, I want to do something. I am a police officer, I want to do something. And one of those emails was Ewen Wang from Stanford. And she said, I'm a pediatrician professor at Stanford, I'd like to do something. And I said, please put together a team of medical doctors, pediatricians, and pediatric behavioral health specialists to go with us to a former Walmart where over 1,500 children were being kept. And she put together this, rock star team that included Paul Weiss, who is the moderator for today's session. And as you heard earlier, Paul became so invaluable through those visits and what he saw that he was asked to directly advise the court in Flores as to what changes need to happen in the facilities where children were arriving in order to ensure that they stopped getting sick and dying. And so, Paul, I'm going to hand it off to you to lead our medical and behavioral health panel.
Thanks so much, Warren, and thanks for inviting us to this important event. The basic premise of today's conference is that effective advocacy for migrant children and families requires diverse disciplines, a coherent integration of diverse disciplines. But it also suggests that the challenge to our advocacy is always evolving, that this is inherently dynamic, and that the status quo is not only not particularly effective, but it's also unacceptable. And that we will need to work together more boldly with greater energy in the months and years to come to address the changing political and demographic challenges at the border and in our political environment. It also, today's event bravely recognizes the power of the arts in shaping public advocacy. And that is critical, particularly for academics and lawyers, because we're talking about shifting humanitarian norms and humane public discourse. And you can't do that just through mere argument, logic, and mandates. It has to be felt. And that is the kingdom of the arts, of poetry, of music, visual arts. And I'm just so proud to be part of a conversation today that has not only incorporated the arts, but elevated them to a central role. This panel, as Mar mentioned, of medical professionals are here in clear support of collective action with the artists, with the lawyers who are also engaged in this struggle. And collective action requires solidarity. And solidarity requires self-affirmation. We have a lot of that today, but it also requires self-awareness, self-criticism, and self-provocation. And one of the things we want to do with our panel today is to provoke, not to merely repeat what has already been said today, which is fairly common knowledge in most of the advocacy community here about the challenges to migrant children's health and well-being coming through the immigration processes. I want to begin by introducing our panel, and this really is a panel of rock stars in the pediatric mental health world. First, Ewen Wang, a close friend and colleague at Stanford for now many years. Ewen is a professor of emergency medicine and pediatrics at the Stanford University School of Medicine. She also is a director of a new master's program at Stanford for medical students who are going to commit their professional life to health equity. Also, she's also received a major grant along with Ryan Matlow, who I'll introduce in a minute, at Stanford to develop innovative new models of services for migrant children, particularly unaccompanied children, once they are released into the United States. Ewen also served as the medical consultant to the plaintiff team mediating the new Flores agreement that was signed in July 2022. Next is Janine Young, who is a professor of pediatrics at University of California, San Diego School of Medicine. She's also the chief of the Division of Academic Pediatrics there, has long been a powerful voice for migrant children's health and well-being. Up until last year, she was here in Denver and was medical advisor to the Colorado State Refugee Services Program, and also the director of the Denver Refugee Health and Human Rights Clinic here, and now continues to pursue her work in San Diego, and I expect will be doing work across the state and beyond to address kids' health at the border. Next is Ryan Matlow, who is a child psychologist who has been extremely active in the legal advocacy community, focused on the mental health and well-being of migrant children, both in detention and beyond. He's also an associate professor of psychiatry and behavioral health at the Stanford University School of Medicine, as I mentioned, working on a new exciting program to come up with new innovative models for children's health for migrant kids once they're released. Last, certainly not least, Alan Shapiro, who you've heard from earlier. Alan is he's also co-founder of Terra Firma, which was really a highly innovative medical program providing wraparound services for migrant children, particularly unaccompanied children, once they're released into the United States. Alan has also been heavily active with the American Academy of Pediatrics, both as an advocate, but also providing real content experience and supporting a legal action, as Lee mentioned earlier, for the enhancement of services for migrant children, once they're in the United States. I would like to begin with an observation, something that I have experienced in my own advocacy in my role as the juvenile care monitor for the federal court overseeing Flores. I should also mention, hasn't been mentioned yet, that the role of the juvenile care monitor, all monitoring for Flores by an independent monitor, is going to end December 31st. That's part of the 2022 agreement that was mediated between the sides. So my role is going to sunset, unless something else happens, December 31. one of the things that Lee mentioned that's come up a lot is a kind of underlying tension that can arise between the medical community and the legal community in advocating for migrant rights, and that the legal community and immigration advocates can be very focused on changing immigration policy more broadly. And immigration policy, particularly as the clip that Lee showed, is a poisonous political environment, highly divisive. And for some, particularly in the medical community, the pediatric community, looking at what children have to go through detention, upon release into the United States, have tended to elevate the humanitarian concerns that basically argue you could be pro-immigrant, you can be anti-immigrant, you could be conservative red state Republican, you could be progressive blue state Democrat, you can be progressive, liberal, conservative, we don't care. But as soon as a kid comes into US custody, as soon as a kid comes into the care of the people of the United States, we take care of them, and we take good care of them. In other words, it actually emphasizes, it distinguishes itself from the immigration policy arguments that may be argued in the legal arena or in the political arena, to elevate the humanitarian concerns regardless of the broader immigration policy. And that can create tensions. Today has been a day of kumbaya for the lawyers and the doctors, which is how we like to operate. But there are tensions that can create different approaches, different emphases that I have witnessed, I have felt, and it's important to recognize and discuss at some level. I'm going to turn to Ewen first, because Ewen was the primary medical consultant for the plaintiffs in the Flores negotiations, and experienced firsthand both the beauty of the relationships, but also the tensions and the struggles in how the medical and legal approaches can both support each other, but also collide. So Ewen, tell me a little bit about that experience and how you would suggest we recognize it, but also overcome to create the coherence of advocacy that the world requires.
So I'm going to back up just a little bit. And I want to elaborate first on how I got to know Warren and got involved. So this was right when Trump's separation policy.
I can't hear you.
Oh, you can hear me now? Okay.
Just right.
Hello, can you hear me now? Okay. So I just want to elaborate on Warren's story and just say how I got involved in this. And it was right when Trump's separation policy became public, and there was huge outcry, medical outcry, societal outcry. Everybody wanted to help somehow. And as Warren said, she put out an email looking for child welfare experts. And I answered that email as well as the 10,000 other people, and got no response. And I distinctly remember maybe 3 months later, coming back from work or something, worried about the issue, and I decided to write Warren again, just because. And she answered within 20 minutes. And not only did she ask me to put together a team of experts that spoke Spanish and that could get to the border within 1 week. So I just want you to know that. And we went to Casa Padre, and I'm a physician. I knew nothing about law. And, you know, again, it was just any way that I can help. And we went, and it was just a crash course in how lawyers were thinking about how they could reverse this very damaging law. And again, I had to be told, I'm like, you know, you don't need medical school to know that child separation is bad. You just don't. You don't need medical school to know that being cold and hungry is bad. But the lawyer said that it was helpful that I had an MD, so I'd repeat what they said. And then I, wrote seemingly self-evident declarations saying, yes, I'm educated and this is bad for health. And then it got a little slippery because, and then my next experience with this again was I was on vacation in Germany, and a lawyer reached me at the middle of the night because they were trying to get somebody out of detention, out of CBP. And they said, you're a physician, you can help us. And I'm like, I'm a physician in Germany on vacation, and I haven't seen these children, but yes, it is bad to be in detention and, cold and without food. So yeah, I'll write this declaration and I'll sign it. And then somehow I got involved with we went to Clint together, completely outraged. And then somehow I ended up, I didn't even know the name of what I was doing, Paul. I ended up going to LA, as the Flores settlements medical expert. And that was really, again, an experience that I just had to learn. I'm an emergency physician, so I can do a very quick kind of learn about preliminary resuscitation. But human physiology is so simple compared to the legal framework, and so, even though I was trying to support Flores, it was very hard to figure out how, just because the lawyers were also very kind of numbers based, right? So, well, we should make an argument that, all the mats have to be 3 feet away, and XYZ, and something that Mr. Gallant said, what age is bad for separation? What age is the worst age for separation? Like, what am I going to say? And so trying to learn how to support the big principles and a system. And luckily, Paul was with, advising the government. So I would try to take his the court. See, I'm still learning. And I could take his lead because, in some ways it was a very, very pragmatic role, right? I did start out, and I don't know if Paul remembers, but I did go on the record as saying all detention is bad and children should not be detained. But it was kind of a no-starter, And then after that, kind of listening to and speaking with Flores Council about what was doable and practical for the children that could be enforced, if that makes sense. And again, it was really helpful having Paul there, who could also speak to the function of CBP, which pediatricians tend to view as evil, but they have a function, and really learning to speak professionally about, advise professionally about the needs for children. And so that was kind of the role of, number one, learning how to advocate on the lawyers, the immigration lawyers' terms for that language, and to support them. And hopefully, well, things worked out. It went on for a long, long time. And then I just want to say, because Paul said we're supposed to be provocative, afterwards, or I think it was in the middle, because we were just waiting and waiting. I mean, we had the last what a mediation that we had, the public mediation was, before the pandemic, and then things shut down, and then, 2 years for an agreement or the settlement. But I contacted Ryan and Alan as partners in crime because we were saying, well, this is good. They've ended child separation, but undoing is just not enough. Okay, so it's the lawyers' jobs now to get the kids into the country. Okay, but once we get them into the United States, we still have an obligation. And a lot of that is medical, but we also need systems changes, which comes from the lawyers. So I'll stop there.
Thank you. I should just mention quickly that the issue of age, what's okay for separating a kid from a parent, is active once again because CBP, I filed a report last Friday that documented that CBP in the Rio Grande Valley was separating the children from their parents while in custody. Once they're released, and almost all the families are getting released, they are back together. It's not like the Trump separation under zero tolerance, but the family is apprehended. The kid will likely go with the unaccompanied children holding cell, and the parent will go to functionally an adult holding cell. And the question became, well, it's really not that harmful. We don't do it to any kid under 8 years of age. So the question came up immediately, well, is a 9-year-old okay? Is a 12-year-old okay? Now, the CBP has routinely, basically forever, separated older teenage boys if they are apprehended with their mothers, because otherwise they'd be holding 17-year-old boys with all the other mothers, some of which are 17 years of age, and nobody felt that was a good idea. So they were always separating older teenage boys if they were apprehended with a mother. But this was new because it was younger kids. They were separating girls from their mothers, boys from their fathers. And this issue of how traumatic is it going to be, even if it's for 4 or 5 days, for a 9-year-old to be separated, has come up once again. Ryan, I'm going to turn to you for some more provocation. And most of the time we've heard it, I would say generally today as well, is that children in custody are generally viewed or portrayed as victims. And my experience talking with now thousands of kids in these facilities over the last 4.5 years is that that's not always either accurate or the most useful in conveying their true experiences and the true harm that's done. Could you talk a little bit about reframing how our narrative should actually be expressed publicly and amongst ourselves, amongst advocates, in rethinking how these kids' experience is more accurately and more usefully portrayed?
Yeah, thanks for the question. And it actually provides the opportunity to pick up on your last question, right? Because it's actually interesting when we think about lawyers' roles. We were talking about this yesterday. We talked about attorneys' roles in asylum cases. Sometimes the mandate is to talk about how children have been victimized or abused or have been vulnerable. And that's what wins the case, right? And so it does bring up this tension because, as health professionals and health providers, we are focused on, bringing forth the strengths and protecting and advancing the health and capacities of kids, right? And so there's a tension immediately right there in terms of just our professional roles and what is the emphasis of how we view or how we discuss the kids that we're working with, right? But as you're also saying in the question, I mean, I'm going to draw from my personal experience as well. You know, I've gone and visited and met with kids. I've joined the monitoring visits. I've met with kids in Tornillo, in Homestead, in the influx facilities at Fort Bliss, right, as monitoring teams. And every time I'm kind of bracing myself for the horror and the trauma and the suffering, which we've heard a lot about, which is part of an important testimony in raising awareness, right? And I'm bracing myself and preparing myself for what I'm about to see. In my experience, what I end up walking away with is more a feeling and story of strength and resilience. Of course, I'm impacted by, and I vicariously experience the depression, the anxiety, the post-traumatic stress that so many kids are experiencing and suffering from as I meet with them and I sit with them and hear about their stories. But I come away from these visits more with stories and feelings of strength and resilience. It's incredibly remarkable what kids have survived in their home country during the migration journey, the ways in which they maintain hope for their future, maintain a focus on their goals, right? What they hope to accomplish by coming here, you know, finding safety, seeking opportunities for education, for employment, ways to support their families back home in their home country, right? The families that are still there, and all this that they're carrying with them. And this is kind of at the forefront. And then also the ways that they naturally find to build community amongst one another. You know, one of the kind of just quotes or stories that I remember from one of the kids I met with, I think at Tornillo, was just that somos hermanos. We're all brothers. We come from different places. We have different backgrounds. We have different experiences, but we're all here together and we're here to support one another. Unfortunately, so often, like, the systems are not providing that support. The kids organically develop this support network and have the internal resources and sense of community and connectedness that they find ways to support one another. And unfortunately, our systems are not necessarily facilitating or providing that support, and in many cases are undermining that strength and resilience, right? There are, you know, I'm a trauma psychologist, there are particular conditions and subjective experiences when someone is facing threat and adversity that increase the risk for trauma, for an experience to be experiences as traumatic, right? When you don't have a sense or understanding of what's going to happen, when the situation is unpredictable, when there's a kind of pervasive sense of danger or threats to safety, when you don't feel a sense of control or agency over what's happening, when you don't have access to the typical resources that you're used to accessing, right? Family support, social supports, community supports, cultural supports, right? And these are the things that are so often taken away from kids when I hear about their experiences. They don't know what's happening to them. They don't know how to impact their case, or to kind of, they don't know how to manage their case, or what are the prospects for their release to their sponsor, right? And so in many ways, you know, the systems are creating these kind of conditions for trauma and undermining, you know, the resilience and strengths that the kids are coming with. And so we do need a systems reframe, and we do need, you know, I believe we need to kind of really focus and perhaps, and in many ways, shift the kind of principles and priorities that we're anchoring ourselves in this work. Again, we've talked earlier about it so often, you know, we're anchoring around, or the immigration system is anchoring around enforcement or deterrence, right? And I think it's important that we maybe, you know, as legal professionals, as health providers, as, you know, individuals, you know, as immigration processing systems, as, you know, governmental systems, it's important to anchor in these principles of providing information, providing a sense of agency, providing access to resources, right? So that there is, again, we're not undermining kids' natural resilience and capacities, and we're really strengthening them, right? And this is true, I'm talking about, you know, experiences within immigration custody, but the same is true post-release, right? In our communities, our healthcare systems, our service systems are not necessarily designed, you know, for this population, for this community, right? You know, there are a number of ways in which our healthcare system is not perfect and dysfunctional as it is, and we're trying to fit kids into some already broken system, right? And so we really do need a kind of redesign of what our systems look like with this particular community and population in mind, thinking about what are the ways that we can cultivate the natural resources and assets and resilience that they come with, and help to leverage those and help them, you know, help to support their empowerment as they move forward and as they settle in our communities. Again, following what Ewen mentioned, you know, the kind of responsibility to take care of and protect all children that are in our community, and to, you know, these are the things we want for any children that's a member of our community, or a member of our home, or a member of our household, right? And so there is a system redesign that's needed to promote that, to work towards those ends.
Thank you, Ryan. I'm going to turn next to Janine and Alan. Actually, all the unaccompanied children are going to be released into the United States. And these days, the vast majority of families are going to be released into the United States. Janine and Alan are world experts on the struggle to provide high quality medical services to migrant kids and their families once they're released into the United States. Let me start with you first, Janine, to talk a bit about not only what you've experienced as the major obstacles, but also where you see the most important next steps, particularly the collaborative next steps between the legal and the medical communities in moving to address the challenges you confront every day.
I appreciate that question. So I've been working with immigrants and refugees for my entire career of 20 plus years now. And things have changed a lot. When I started doing this, we didn't have hundreds of thousands of children coming across the border because we weren't in a situation where there's crisis after crisis, there's climate change, this is not going to go away. War-torn areas, the Northern Triangle countries. And so starting in 2014, when the first large wave of unaccompanied immigrant children started coming in, I noticed, this is across the news. And I wondered, and I asked myself, because I was doing a lot of clinical medicine in a federally qualified health center here in Denver, where are all these children? How are we identifying them? How are they even showing up in our health system? And how do we even know that they're there? And also started talking to colleagues, medical colleagues who didn't follow this, didn't know about it. And I was trying to increase awareness about this as an issue in general, because this is a huge issue in the United States to have, suddenly Doctors Without Borders come to the United States to do humanitarian work. That is a game changer in my mind. I always, you were brought up with this American exceptionalism. And, after listening to our speakers today, I'm sad to say, and this is a pessimistic view, but, we're not exceptional and we need to do things better, much better. And so I started looking at the kids that I was seeing in a high volume federally qualified health center. So you see 12 patients a session, they, mostly are speaking Spanish. Yo hablo completamente en español. And so I speak Spanish fluently. And I started to ask children more about their journeys. And, you need to establish rapport with a family or with a child who comes in on their own. If they're a teenager, if, it's a confidential visit, the guardian goes out of the room. And so you start asking, you establish rapport, you're speaking the language. And I would start asking, how did you get here? And the answers were staggering. And the staggering answers were I walked, I was on a donkey, I was being recruited into a gang, in Guatemala, where my brother was killed and I saw my brother be killed. And they would just share these stories. And I started asking more, how did you get here exactly? And they would share with me, well, I got to the border and I was detained and I was put in la hielera, I was put in the ice box. This is the stuff that we've seen on the news over and over again. And so I'm seeing it day after day. And my colleagues are as well. And I started discovering by asking these questions, oh, you were put in la hielera. And in fact, I was by myself, or I was separated from my older brother because he was, not my guardian, or my grandpa came with me, but he was held and I got put into detention by myself. And so I realized that this is the group that we're not identifying across the United States. And I can tell you, looking at my colleagues here, pediatric or otherwise, is we are not trained to identify these children. And we still are not trained to do that. And so I started to ask, and then I started to realize that these kids are, they're hidden in plain sight. And we need to do a better job of identifying these unaccompanied children who've been held alone, been separated from their families. And we need to not only identify them, but get them legal services and get them wraparound services that they need. I would argue that unaccompanied children are the highest risk population in the United States, and we're doing nothing for them. There's no once they're released from Office of Refugee Resettlement, there is no federal organization that's following them. There's no funding to follow them. And so what ends up happening is they come to emergency rooms, they come to clinics, they come, they're admitted to the wards, they come to federally qualified health centers. And if we're not trained to ask to identify them, were you by yourself, which is a proxy for being an unaccompanied minor, then you're never going to identify them at all. We need to identify them because you can get records from Office of Refugee Resettlement, you can get vaccine records, you can get some of the minimal testing that is done by Office of Refugee Resettlement, which is sorely inadequate, frankly, for these kids, at least so you know whether they've been tested, whether they need to be treated for tuberculosis. And so I started to link and partner with nonprofit legal agencies and organizations in Colorado when I was still here, and I'm doing this in San Diego as well, to provide the wraparound services that these kids need. Only a small percentage of these children are assigned what is called a post-release service social worker. And ironically, these kids, so there's this group of unaccompanied immigrant children, and ORR somehow decides that there's a subgroup that's high risk, which is, the irony is just shocking to me. And that small group of children get extra services for 4 months. They have a social worker assigned for 4 months who follows them and links them to supposedly legal aid, school, housing with their sponsor, and healthcare. The vast majority of these kids get none of this. As soon as they're released, they're hidden in the United States. And these kids are trafficked at a high rate. And this has been reported in the New York Times. So I think, what are the obstacles to providing care? I think there are a lot of obstacles. One of the obstacles is not being able to identify these kids and not having providers who are trained to identify them nationally. There's no training for providers. The obstacles are that they all need medical screening and they're not getting it because the medical providers in the United States are not trained in immigrant health, which I would argue is a field of medicine. So they're not getting tested for hepatitis B universally. They're not getting tested for HIV. They're not getting tested for parasitic infections because Office of Refugee Resettlement is not doing that. And then I would say, for next steps, I think funding needs to be provided to systematically train providers to educate people nationally on these issues, to identify these kids, and to begin to provide wraparound services.
Al, I turn to you.
Same question?
Same general
Okay.
question.
Okay, so I'm going to try to answer it a little bit differently than Dr. Young because I just want to be able to cover all the issues that we will never be able to cover in this session. But I want to start with, especially if there's any medical people and primary care people in the room, to say how important primary care is. And I think it's not given its due recognition in the sense of being a sentinel. And what I mean by that is that if you're on the street, if you're in the community, you're seeing trends, whether it's medical conditions, whether it's population changes, whether it's threats, whether it's challenges that folks in the hospital system are not going to see. And we are in a very privileged place to be able to identify trends in healthcare and social trends that really no one will ever be able to see except us first. And I'll give you an example. So I was working for about 24 years in a mobile medical unit, working with unhoused street youth in New York City. And we had a young boy from Guatemala that was brought onto our mobile medical unit by the drop-in center counselor. And he turned out to have schizophrenia, and he was not able to tell us really anything about himself, but he had a card from his legal agency, Catholic Charities. We called the lawyer, and we found out that this young man was an unaccompanied immigrant child, unaccompanied alien child, as the government calls them, unaccompanied migrant child. And we learned, I had been working with, just like Janine, with immigrant children my whole career, 30 years, and I had never really never heard of that designation, which actually gives children protection and gives them rights. And we found from this lawyer that there was an increasing number, this was in 2013, of unaccompanied children coming into New York City and into the country, followed by the big first surge in 2014, and that they were looking for healthcare providers that was specialized in the type of care that immigrant children needed, and also that we were willing to identify problems, whether it's physical or mental trauma, that could be placed into affidavits, that could be used as evidence in court cases to improve asylum rates or other forms of getting humanitarian relief. And so that was sort of what launched our program called Terra Firma, which turned into a multidisciplinary clinic located in a federally qualified health center that had a legal team on site working side by side, pediatricians, social service agency, and mental health staff. And that children from the community were referred into our program by lawyers, schools, churches, word of mouth, other healthcare providers, and that they then were able to all of a sudden bring children with this unbelievable complexity of need into one place to get all services in one place at one time. And that is, sort of a long way of coming from where I started with this idea of primary care. Because without that, it'll be going, I have the privilege of saying I worked in the 90s and saw what happened in communities like New York City without primary care, where kids would only get their care in emergency rooms, and where, asthmatics would end up almost, would end up in ICUs because they didn't have a doctor to monitor their care. And this is what 1990s was like in the inner cities of the United States. And so unaccompanied children are really kind of placed back in the 90s in that way, because they have no access to a medical home. Let me just put it that way, into a medical home. And a medical home is so critical for these children, because not only does a medical home provide comprehensive services, including hopefully mental health services, but they also are advocates for children. And it's actually through that work that I started to see all of these children, that I heard the stories that Janine were talking about, the migration pathway, La Hilera, the Casa Hogares, which is the shelters that children get placed in, and start to understand the complexity of their whole migration pathway and the compounded traumas that many of them have endured along the way, from pre-migration all the way to my clinic. And it was like that learning experience, what I always say is, as advocates, we have to be witnesses. We have to learn from our patients. We have to share with what we learn, and then we have to act on what we learn. And that is a really important role of what we do. And I don't know if that answered your question at all.
Perfectly, as always. I'd like to turn to the audience here and online to ask questions, pose issues to the panel. Anybody have questions, comments? anger? Please.
Hold the button.
Sorry. My name is Laura Vargas. I'm an assistant professor of psychiatry here, and I do research on mental health and trauma exposure of immigrant adults. So to the question of finding the children and getting them care, I kind of struggle with how, not just the training that physicians may or may not have in asking questions, but also how open are the systems that we have of care to taking in children once you find them, if you ask the questions. So that's something that I think I struggle with, and I would really love to hear your thoughts on that.
I think. Oh, sorry. I can start. I'm gonna just take this off. I appreciate that question because I think the ethical issue of screening and then not doing anything is hugely problematic, and it's hugely problematic in medicine in general. And so I agree with you, and I think you had said this, my colleague here, that you know, I mean, we have a broken healthcare system, unfortunately, and siloed systems. And so it's sort of battling an uphill battle and kind of swimming upstream. But I would assume a lot of people in this room want to swim upstream with me. And I think you're one of them. And so, I mean, you beat your head against the wall a little bit and then develop partnerships. So I'm a physician who thinks social justice is incredibly important in the provision of care for children and families. And so I do that by when I meet a child who answers that question and says, well, this person next to me is my sponsor and I just met them, which is pretty common, unfortunately, that I'm going to find someone like you to counsel them, or you. I'm going to find a pro bono lawyer like Warren or others. And I'm going to develop these partnerships. And I think this is the key to this whole meeting, is developing these multidisciplinary partnerships, because there's power in numbers and power in differential expertise. And so I would encourage you to find your partners here in this community and then start fighting. Yeah.
I should point out that this world-class group represents New York and California, 2 of the 11 states that provide health insurance for migrant kids. I get texts all the time from pediatricians and lawyers saying, this kid has a significant medical problem. We can't find any facility who will take them because they're uninsured. So the reality is that they're entering into a system at extremely high risk, into a system that is broken for everybody, but particularly for migrant kids in most states. Other questions or comments? Scott?
So I just wanted to follow up with that and maybe drill down further on behavioral health and psychiatric services, because I think while there may be some of that available in those 11 states, it's very hard to come by. And first, I really applaud the multidisciplinary approach. Obviously, our office does that just on the legal side for advocacy. But when you're incorporating what you're doing, Alan, at Terra Firma for so long, and what Ryan and Ewen are about to embark on, it's so critical. However, what we're finding right now, and this is for English-speaking children in the domestic child welfare system who have Medicaid eligibility, we have trouble finding therapists for them right now, just like anybody in the private pay world, in the private insurance world. Any therapist can make a lot more money now treating that population than taking Medicaid payments, including, and then if you take Medicaid clients who have trauma, the kind of trauma we're talking about, they're more difficult, challenging cases. You get paid less and you don't get paid for no-shows, and our clients no-show a lot. And then when we have our Spanish-speaking clients, to find Spanish-speaking therapists, behavioral health, it's just about impossible right now. How can we project forward 3, 4, 5 years to build that kind of capacity that we don't have right now, because it's so critical to the success of any multidisciplinary approach, and it's so critical to our youth.
Let me ask Ryan to take a first crack at that.
I'm going to borrow one of Paul's responses. I don't have all the solutions, but we're, recognizing the problem, right? It is surely a capacity issue. And to your question, sometimes it's, the systems are not open, right? Not always open. Sometimes it's willingness, but sometimes it's capacity, right? And so this is part of like the system redesign of finding ways to support, fund, cover the effort that's involved in this kind of complex care, the care coordination, the no-shows, coordinating, working with an attorney is not typically reimbursed. It's not covered, right? So, I mean, that's part of the advocacy work for us all to do is how do we, whether it's policy change or finding ways to connect and collaborate around identifying the funding streams and the funding mechanisms. And there's more resources that are needed. And this is, banging a drum that's been, been beaten multiple times about how do we find the resources that are needed to build a system where there is capacity to provide the services that are needed for this community, for this population. And I would say that part of this is, requires some creative thinking and maybe thinking outside our normal practices around what are the avenues and opportunities for healing. And this is where the arts come in. This is where I'm so appreciative of this symposium and this forum, is that it's not always through psychotherapy, right? It's not always through psychiatric care that kids heal, right? And particularly, many of the kids, the cultures and communities where many migrant kids are coming from, is that the point of entry and the opportunities for healing are not necessarily aligned with our traditional kind of healthcare systems or healthcare service delivery. And so we need to incorporate and involve these other programs. We're working with partners in Half Moon Bay who their primary program, their kind of gold standard are cultural arts programs. And this is the point of entry for so many kids, where they get healing, where they get to access and utilize and kind of reinforce the natural supports and assets that I was talking about earlier, right? And so this is part of our, healing process and part of the ways that we can kind of address the needs. And again, thinking outside the box and thinking about how we can come together across our different disciplines and modes of work to really provide a system and a service that is aligned with the backgrounds and priorities and assets of the kids, the migrant kids that we're speaking about.
Alan?
Just to also address your issue, this is not going to happen passively. It just will not. And so you need to be the champion for this kind of change. You have to say, I have incredible experience with immigrant children in trauma. Who are the pediatricians, or who are the adults in your case, who are working with this population, and start working together? If you don't work, it's just not going to happen. And you really have to drive that change. I think one incredible example of why this is so important is the pandemic and the effects of the pandemic on very vulnerable populations. Is that if you don't have these systems in place and you make getting healthcare, for instance, what we call the chilling effect of the Trump years in terms of accessing healthcare. Remember the chilling effect of the xenophobic policies of the Trump administration, followed, the pandemic, or preceded the pandemic. So then you have all of these folks that are afraid to access healthcare, and then you have a pandemic. And who were the folks that died the most? And who were the ones who got the sickest? And so you have to put these systems in place so that when something like this happens, we're ready. And I'm thinking about New York City now and the 113,000 migrants in New York City, and how groups are now just kind of having to snap into action to start addressing the needs of an unprecedented surge in New York City.
Thank you. Yes, sir.
Got to make sure I can hold the button down. Thank you for what you're doing. I think it's state of the art. It also seems to me to be standard of care that we do this kind of multidisciplinary practice. But you said you were going to provoke. I'm going to take on the role, but for the same purpose you said, which is to get us thinking. I followed post-Katrina developments, and I found it very interesting that there were reports in newspapers and a few comments by professionals that we still don't know where the children of Katrina all ended up. Now, there's a thought. So whether we're dealing with domestic or international issues, as you look at the world with war, natural disasters, epidemics, pandemics, you ask yourself the question, are we ready? And one missing element in this conference, which is absolutely wonderful, is the human services agencies. And I'll make an editorial comment. Human services agencies tend to be morally driven, but not scientifically driven. We don't have them here. Yet, we are going to have to rely on them to bring a lot of these cases before the judges to make sure that in placement decisions, who else is going to make placement decisions? Who else has the authority? Who else has the resources? So somehow we've got to find a way to integrate better with them. And we've also got to find a way to urge their science or evidence-based improvement.
Excuse me, but could you clarify what you mean by human services? You're talking about child welfare agencies or?
Primarily public child welfare, but there is clearly a role for religiously based and private placement, adoption, fostering agencies. And so that when, for example, we talk about placing children out of home, it's still back in a political framework. And there are situations where there are no parents. Sometimes we've created that situation, but sometimes events create those situations. And we have to get around the idea of making this solvable, thinking it's solvable. In politics, we have work to do, it seems to me at least, in terms of scientific research, looking at when that is a necessary decision, and if it should be necessary, how do we assure ourselves that that care will not be more harmful than where the child was before? It's as if we're back in the 1800s where people thought hospitals were a place to go to die.
Thank you. I should also point out that the Department of Homeland Security, the Office of Health Security, has created a new program to function in CBP detention centers for kids called the Child Welfare Specialist Program, which is going to place 2 licensed social workers in each Border Patrol sector to oversee the quote-unquote trauma-informed care programs within the CBP facilities. That's coming out now. They're hiring into it, and the hope is not they're going to provide therapy for all the kids in there, but create systems within Border Patrol that are more reflective of the expertise of the science that can address the profound stress and potential damage that gets done both for the unaccompanied children and children families held in CBP.
So as we look at innovations, Cindy Christian at Children's Hospital of Philadelphia took a sabbatical, went into the center and said, hey, would you guys like to have nurses go with you sometimes when you visit families? They said, no, we don't need that. But when she left, they had 4 districts in Philly, 2 nurses in each district so they could fill in for each other on vacations. And it turned out to be enormously helpful in addressing the needs of families.
Good. Yes.
We have an online question. I appreciate the discussion about the strength and resilience of many of the unaccompanied youth. I think it makes sense within our advocacy communities to reframe things in this way, but isn't there still some value in public discourse to continue to label them as victims? Because of course they are that too.
Want me to take that? You want to take that? Why don't you take this?
Initial response. I mean, that's the tension, you know, that we kind of have to hold there. Sometimes there is some advocacy value, right, in talking about the harms, the atrocities, the abuses that kids have gone through, right, and as a way of advocating, right. But I think it is problematic at times, and it, you know, especially the risk for kind of internalizing that mindset and that frame that I'm a victim, right, or you know, we've seen kids, you know, suffering from some of the shame, the internalized guilt and shame around kind of their identity, right? And so if we just stick to that frame or that lens, and then that there's risk, and there's, you know, that's somewhat problematic. So that's a line we have to toe. But we like, you know, what I like to do, we like to do in our practice and our therapeutic work is to acknowledge the harms, the adversities, the traumas that kids have overcome, and really reframe, help both in kind of our perspective, and our take, the service providers, but then also for the kids and families themselves, is to reframe that as survivorship, right? That we've overcome, this person has overcome such incredible adversity, and let's look at the strengths, the positive qualities, the resources, the resilience that help you to survive, right? And so it's a tricky question, and maybe it depends a little bit on context. What's the appropriate kind of language or terminology or frame to use? And I think we just have to be cognizant of the different implications of this frame. Yeah.
The danger is we strip them of their humanity, the complexity of who they really are, something that I'm reminded of every time I'm in these facilities. And that's where the arts come in. I'm rereading David Copperfield and Demon Copperhead. And the nuanced portrayal of their humanity comes out so powerfully, both Dickens and the more recent Barbara Kingsolver novel, that it's instructive, and it creates a kind of caution in how we advocate to ensure that we continue to embrace their full humanity. I hesitate when I talk about my experiences talking with particularly unaccompanied kids, is sometimes it is heartbreaking, often. Sometimes it's actually hilarious. I'm not supposed to say anything about what I see, but I think this is okay. I was in with the unaccompanied teenage boys, and we're talking, and finally I say, okay, good luck. You're going to go to a better place than this soon. And they said, one of the 16-year-old boys comes over, puts his arm around me, and he says, hey, Doc, we got something for you. And 4 kids break into Spanish hip hop that they had devised, they had created about being in the CBP holding cell. They've been there for 24 hours because almost always the unaccompanied kids leave CBP within 48 hours these days, often even faster. But it just made me laugh. Not only the words that they came up with, but just the creativity and their sense of humanity that is also somehow important for us to convey. It also keeps us going, but also is important, I think, to use as part of our advocacy positions. Yes, please. Hi. Is your microphone, please?
Thank you. I wonder if you might speak to your own experience in arts engagement and how arts engagement may have made you better providers, whether it means more curious or more grounded in social justice or more attentive or more resilient yourselves.
Who would like to take the first crack? I will chime in, but they're looking at me like, well, I didn't introduce myself. I'm Paul Wise, Professor of Pediatrics, Health Policy, and International Studies at Stanford. My work is focused on children's health and well-being in complicated political and security environments, often war zones. And I've been working a lot in Ukraine, and we recently published a series of essays on rethinking humanitarian health response to violence. And we asked artists and poets and novelists to contribute. And to me, this broad sense of the humane damage, the human damage that's being done in these settings is best conveyed, I think, as we heard, and I think you'll hear tonight in the sessions. The complexity, I think, is crucially important. The stories are crucially important. But I also think the diversity of expression, photography versus songwriting versus short stories, poetry, can paint a picture that no academic article could ever portray around these kinds of issues. The work we do analytically, I would suggest, is important. We need it, but it's inadequate. And I'm really glad that brilliant conveners included that as core for this, because I don't think it's helped enough. It's also crucial for the sanity, levels of energy for all the people trying to take care of all these kids. It's crucial because that's where the strength comes from, the resilience. And many people ask me, well, you've been doing this for 4.5 years in these detention centers, you become numb. And the answer is, it's the opposite. You become hyper aware of these feelings. You have to embrace these feelings because a lot of the feelings are energizing. I come back from a visit to the border exhausted and energized. That only happens if you have this nuanced sense that is best captured, in my view, by the arts.
I'm not an artist, and I think that was why we're all hesitant to respond. But I will say that, you know, as a pediatrician, and I'm sure all of you in healthcare have experienced this, is my patients will draw, and they're better artists than I am, I will tell you that. But what they draw tells me everything that I need to know. And it can bring me to tears, or it can make my day. And it really gives me a sense of kind of what's going on and level sets where kids are. And so running a refugee clinic and having kids draw horrific pictures, but then when I see them back in a month, they're drawing, you know, something nice and beautiful, means everything to me, actually.
Any other questions or comments? Well, let me thank the panel again for not only their comments today, but all the amazing work, inspiring work that you're doing, to Warren and the critical people who put all of this together. To close, I should mention that as we have been speaking here today, there have been 1,500 individuals and families apprehended and brought into custody at the border. Been close to 350 or so unaccompanied children who've been apprehended and brought into custody as we speak here today. The scale of the issue is enormous, and therefore the scale of the challenge, the potential tragedy, and the potential triumph has to be kept in mind. My hope is through these kinds of conversations, cross-disciplinary, transdisciplinary conversations will be the best guarantee that our policies and programs will ultimately prove humane, effective, and just. So thank you all.